Yeah.
Good afternoon all. I'm Dr. Sampada Kulkarni. I'll be presenting on optic nerve hypoplasia, severity of disc hypoplasia and its association with vision and neuroradiological findings. Optic nerve hypoplasia is a common congenital disc anomaly and is a leading cause of childhood blindness. It is a non-progressive underdevelopment of optic nerve accounting for profound vision loss. It has a wide clinical spectrum of symptoms ranging from vision impairment from neurological to endocrinological abnormalities. If we consider association, it has divided into ocular and neurological. In ocular, it ranges from microphthalmos to nystagmus and strabismus, while in neurological, it can be developmental delays, seizures, urgenesis of septum pellucidum, and Demosius syndrome. The objective of this study was to understand the association of severity of optic nerve hypoplasia with ocular and radiological findings, and to also decide the characteristics between unilateral and bilateral optic nerve hypoplasia. It is a retrospective observational case series conducted from January 2015 to December 2023. We screened folders with ICD code of optic nerve hypoplasia, among which we got 297 folders. In this, 57 patients were included for final analysis with the records of optic disc photographs were available and neuroimaging findings were present. Optic nerve hypoplasia per se is divided into clinically as diffuse, segmental and segmental with tilt. We included patients with diffuse optic nerve hypoplasia. The data was collected in demographics like age, gender, presenting complaints and systemic comorbidities, while for the correlative analysis, we took into account logMAR visual impairment, optic nerve head assessment with photographs in terms of size, double ring sign, peripapillary changes, abnormal blood vessels, and disc diameter to disc to macular distance, as well as neuroimaging findings in all patients who were included. Optic disc assessment was done by a single observer with optic disc photographs in undilated state. The disc was measured both vertically as well as horizontally, and average was taken, and the disc to macular distance was measured from the temporal margin of the disc to the center of the macula. And based on that, the disc macular distance was calculated in terms of ratio. Like in photographs, you are seeing here that from left to right, the severity of the disc hypoplasia is increasing. Neuroimaging findings were also noted in patients. The results were analyzed with the help of STATA software. Median, and mode was included for qualitative analysis. Quantitative and qualitative analysis, we did multivariate regression analysis. P-value less than 0.05 was considered as statistically significant. Mean age in this study was 11.38. There was no statistical significant preponderance for gender. We had more patients with unilateral optic nerve hypoplasia. Strabismus was noted in 87.71%, and the exotropia was more common noted. Most common presenting complaint was blurring of vision, followed by others like nystagmus, loss of vision, and strabismus. When we divided patients based on WHO classification for vision impairment, we saw that we did analysis for right eye, left eye, and the best corrected visual acuity for that patient. And there was a varied range of visual impairment in these patients. When we compared vision impairment compared to bilateral versus unilateral, we saw that most of the patients with bilateral optic nerve hypoplasia had some amount of vision impairment, and more so in bilateral group for profound and severe vision loss. Refractive error assessment had more of myopic refractive error, and it was ranging from mild hyperopia to significant high myopia in these patients. When we did optic nerve assessment in terms of size, we noted that most of the patients had small disc size, and average and large disc size was noted in patients with unilateral optic nerve hypoplasia in the unaffected eye. Abnormal blood vessels like tortuosity of blood vessels and trifurcations of the blood vessels were noted in both the eyes. Double ring sign was noted in most of the patients, and left eye was more commonly involved because in unilateral optic nerve hypoplasia we saw that left eye was more commonly involved. When we graded the patient between mild, moderate and severe optic nerve hypoplasia, we found that most of the patients were in the range of 3 to 5 distance to disc macular distance. When we graded patients and tried to do the correlation analysis based on vision impairment, like in this graph, you can see that x-axis is showing vision loss, mild, moderate, severe and profound, while on the y-axis, we have graded the optic nerve hypoplasia based on mild, moderate and severe and profound optic nerve hypoplasia. We can see that x-axis is showing there is a significant deterioration in the vision loss in bilateral optic nerve hypoplasia. Same thing was happening with bilateral as well, where the common finding in imaging was noted as chiasmal optic atrophy and absent septum pellucidum. Multi-regrade analysis showed that there was a significant relation between the disc distance and midline anomalies with severe vision loss. The strength of the study was single observer, and it was a retrospective was a main limitation of the study. We found that unilateral optic nerve hypoplasia was more common. Severity of optic nerve hypoplasia was a surrogate indicator for neurological abnormalities, and bilateral optic nerve hypoplasia is known to have more neuroradiological manifestations compared to unilateral one. Thank you.
Which type of neurological
Yes, ma'am.
symptom did you find in unilateral and bilateral?
I didn't get your question, ma'am.
So you were saying, no, initially when you did the logistic regression analysis,
Yes, ma'am.
what was your results basically?
So logistic regression analysis, we divided the patient into mild to severe and compared with,
So
yes.
what are the grades you have compared it? So only the optic disc head or anything else you have taken into account? With the severity, visual assessment you have done, no?
Correct, ma'am.
Doing it with the grade of the optic disc.
Yes, hypoplasia,
correlation.
yes.
Anything else? Did you look at the age or anything which is correlated when we're doing a multiple regression analysis? Certain factors are there. So what
Correct.
are the predictive risk factors in this
The
case
most common predictive risk factors in these patients was the increased distance to distal macula. Like severity of optic nerve hypoplasia was, the more severe it was, the vision loss was poor. Along with that, the patient who had midline anomalies, they had a poor visual impairment, like poor vision in the given set of patients. Age was not kind of related, man, because it was ranged from
okay, what are the radiological findings did you find? Which type of neurological?
it ranged from, most common was absent septum pellucidum seen in 30% of the patient, followed by chiasmal optic atrophy and T2 hyperintensities, which were noted, abnormal hyperintensities.
So, did you take any other visual parameters like contrast sensitivity or other things that you measured?
We had checked, ma'am, especially color vision and relative afferent pupillary defect also had checked. It was not included here. But yes, we saw that these all patients, some of them had developmental delay also. So they had other associated visual abnormalities as well.
Other ocular findings? that
We had strabismus in most of the patients. Nystagmus was present in almost 80% of the patient. We had few patients with Brown syndromes and MED also in this situation. 2 patients had microphthalmus and 1 patient was had aniridia. Even endocrinological analysis was also taken into account, and 8 patients had endocrinological assessment done. Among them, 2 had growth hormone deficiency, 1 had testosterone low levels, and 1 had growth hormone deficiency.
Yeah. Okay. I would I would just congratulate you for the excellent presentation.
Thank you, ma'am.
I just wanted to know whether there was any connection between in your series you said that exotropia, exophoria was more common.
Yes, ma'am.
So was it anywhere related to the loss of vision? Because I mean exotropia, exophoria is a position of rest.
Yes, ma'am.
So was it anywhere related to loss of vision?
Yes, ma'am. Most of the patients who had exotropia had poor vision. So that's how it was related.
Very good. Wonderful. Can we call the next speaker, please?
Thank you.
next is
Yeah, just tell your name.
Dr. Divya.
Yeah, Dr. Divya. And Dr. Anvita, are you ready? You're ready? Yeah. Yeah.
A very good afternoon to all. I'll be presenting on cavernous sinus syndrome presenting as a mononeuropathy. So the objective of our case series was to describe clinical profile, presentation and outcomes of patients with cavernous sinus syndrome presenting as a single cranial nerve palsy. As we know that cavernous sinus syndrome can present as a multi-nerve involvement with the third, fourth, sixth and the first and the second part of the fifth cranial nerve. So we went ahead with this analysis where we conducted a retrospective analysis over a period of 1 year at our center. We included patients with acquired mononeuropathy who had radiologically proven cavernous sinus lesion, and excluded those patients who had congenital neuropathies or any other cause of mononeuropathy like ischemia or trauma. Further, data was collected of the demographics, vision assessment, strabismus, motility, their lab workup, neuroimaging findings, treatment and outcome at presentation and at follow-up. We found that in our study period, we observed a total of 287 cases of isolated third cranial nerve palsy and 386 cases of isolated sixth cranial nerve palsy. Out of these, 4 patients met our study criteria, who were all male with a median age of 41 years. Left eye was seen to be more commonly involved than the right. One of the patients had a coexisting diabetes mellitus, which was diagnosed when the patient presented to us. At presentation, all these patients had the complaint of diplopia and that they were unable to move their eye. 2 of these patients also had pain on eye movements. There was no neurological complaint in any one of them. 3 patients had the involvement of the sixth cranial nerve and 1 had the third cranial nerve involvement. All of them presented with the best corrected visual acuity of 20/20. The anterior segment examination was normal. All of these patients presented with a single cranial nerve examination, except for 1 who eventually, after 3 weeks, developed reduced corneal sensation and hyperesthesia of the trigeminal nerve. The rest of the cranial nerve examination was normal in all of them. So we had ordered an MRI brain with contrast, and after getting diagnosed with cavernous sinus involvement, these patients underwent chest X-ray, MON2 test, serum homocysteine, serum ACE levels, blood sugar levels, lipid profile, a complete blood picture, and the ESR count. It was seen that 2 of these patients had come positive for MON2 and were presumed to have extrapulmonary tuberculosis. One of the patients was having diabetes, and another patient presented with hyperlipidemia along with hyperhomocystinemia. All of these patients had cavernous sinus involvement, and one of the patients even had the involvement of the orbital apex. On MRI brain with contrast, we could see that there was a bulky enhancement of the cavernous sinus and with the orbital apex involvement in one of our patients. So further, diagnosis of mononeuropathy in cavernous sinus syndrome was made with an etiology of presumed extrapulmonary tuberculosis in 50% and while that of idiopathic in the rest. So the 2 patients who were MON2 positive were started on ATT, followed by starting oral steroids 1 mg per kg after 2 days. The patient who was a diabetic patient did not have any aneurysm or pupil involvement and was started on oral steroids by their neurophysician. The last case was lost to follow-up eventually. As we can see that all of these patients showed drastic improvement over 1 to 4 months. The main limitation of this study was that it's a retrospective analysis with a small sample size and a short follow-up. But I would like to conclude that cavernous sinus syndrome or orbital apex syndrome may also present with an isolated mononeuropathy, and this could actually be the first presenting sign. It is imperative to investigate the underlying etiology in these patients and not to treat it as just a presumed microvascular ischemic cranial nerve palsy, even though other vascular risk factors may be present. An appropriate and timely treatment in such condition will have favorable outcomes. Thank you.
Did you compare with different any other studies or case reports which are there?
There are single case reports, ma'am, but not a combined study or anything that has been seen yet to show mononeuropathy in a cavernous sinus syndrome or an orbital apex syndrome.
So what other things radiologically do you see that you can conclude, because yours was idiopathic or tubercular,
Yes.
nothing else. So what are the other signs do you get when you see from radiologically that you can say that, or you can say it will be going towards that?
So if we have granulomatous lesions that are present at the cavernous sinus, that could go to a granulomatous type of cause like tuberculosis, that can be seen. And
Granulomatous is easier to diagnose as a
Tubercular,
meningitis.
yes.
Other than that,
we can see if there is any increase.
because you have done the study, so
Yeah.
you must have seen some other features which is coming up. That is
Ask
what
her
I
to
was-
speak on the mic.
As they were diagnosed in a very early stage, most of them presented with just the cavernous sinus bulky granulomatous lesion that it started with. as they were started with ATT earlier only, we did not see any progress because the neurologist had done repeat MRI in these patients over 3 to 6 months post starting ATT, but they turned out to
But
regress.
the patients are presenting initially with a mononuclear
Yes.
palsy to you.
Yes, yes.
So you must have advised for a
MRI.
scan. So,
So-
what did you see? Those findings I just want to know.
Okay,
What are
so-
the different findings did you see?
So, if these patients did not improve as a mononeuropathy within the 2 weeks, if there was no improvement at all, then we had ordered for an MRI, and in them we had found
So you
to
only saw granulomatous.
only
nothing else.
granulomatous, nothing else. Yeah.
I think it was a very nice presentation and very
Thank you.
interesting study also. But
Thank you, ma'am.
what I wanted to know was how many, like, what type of neuropathy did you find? How many complete ophthalmoplegia and how many you had? both,
Yes. So the
partial?
sixth nerve that we found, all of them were complete. The third nerve was pupil sparing, but
all of them were pupil sparing?
yes, all of them were pupil only one patient had third nerve involvement, which was pupil sparing, and the rest 3 had sixth nerve involvement, ma'am.
So, and also you had one patient with diabetes.
Yes.
So, how would you, how did you differentiate? It could be due to diabetes also.
So that patient was having, like, he got diagnosed.
Finding that
Yes.
you're having a cavernous sinus.
Probably because that patient was found to have diabetes with us only. He was not a known case of diabetes before. So when the patient was not improving over a period of 3 to 4 weeks for him, we got an MRI done and then it came out to have a cavernous sinus involvement in him.
Thank you.
Yeah.
Thank you.
Yeah, a very good presentation. I just wanted to know, is it possible for you to tell me the anatomy of the third nerve from nucleus till the muzzle?
Sure, ma'am. So the
From
third nerve
where does it
arises from the midbrain and it goes through, it descends through in between from the red nucleus, substantia nigra, and then from between the PCA and the MCA, it comes down and then it enters into the cavernous sinus, and after that goes to the orbital apex and enters into the eye, where it divides into the superior and the inferior branches to supply.
Yeah. And that was exactly the reason why the pupil was spared.
Spared, yes.
Good, very good.
Thank you.
Okay.
So the next
the next
presenter,
speaker.
Dr. Anita. Anvita, sorry, Anvita, no?
Yes, ma'am.
Anvita, no?
Anvita.
Yes,
She's
ma'am.
Anvita?
Yes, ma'am.
Smriti. Smriti is here.
पहले अपलोड किया था.
मैं फर्स्ट वाले को करवा दूँ फर्स्ट वाले को फर्स्ट
इनका नहीं है.
नहीं
So actually her presentation is not there, so we are calling Dr. Sangeeta.
आप उधर दो मेरे को
वहाँ
The first candidate.
Whoever is the hall manager, can you please come here? The hall in charge? Yeah. Okay, go ahead.
Good afternoon all. I'm here to present my study on comparing the reliability of Ishihara chart with smartphone application color vision testing. Color vision is an important form of human visual perception. The most commonly used tools to screen the color vision defect is Ishihara chart. Nowadays, smartphones are widely available, so installing applications like iHandbook, which allow easier access to color vision testing using the color plates displayed on the smartphone screens. So it is a prospective pilot study done to compare the reliability of standard Ishihara chart with a color vision testing smartphone application done for a period of 6 months from June 2024 to December 2024. This application, it has 24 plates with adequate brightness and the phone is held at a distance of 75 centimeter. Patients are instructed to read the plates within a time frame of 3 seconds. For individuals who are unable to read, they were given 10 seconds to trace the line. It was recorded as normal, defective, a number of plates readable out of 24. So the sample size is 30, calculated assuming 50% accuracy between the Ishihara chart and the color vision smartphone application with a precision of 5% and 95% confidence. So this is the standard Ishihara chart which we are using now. It has circular plates filled with color dots with hidden numericals and symbols in it. So this is the application which we are using in this study. It has 24 plates, similar to Ishihara, with adequate refractive correction and adequate brightness. The patients are asked to read the numbers displayed in it. It is tested monocularly, and the results are recorded accordingly. So the inclusion criteria: best corrected visual acuity more than 6/60, age more than 10 years, and all cooperative patients are included. Patients with mature cataract, psychiatric illness, and known case of color blindness are excluded. So color vision assessment was performed using the Ishihara plates and using the higher handbook by 2 different doctors. The frequencies of age and sex of the participants were also calculated to assess any statistically significant correlations. For the reliability coefficient, a 2-scale Cronbach's coefficient alpha was applied along with a 2-tailed paired sample Z test for Pearson correlation between the color vision test results from the Ishihara and Android eye handbook versions. A p-value less than 0.05 was considered statistically significant. Out of 30 patients examined, 47% were male and 53% were female. 60% were found to have neuro-related diagnosis and 40% were found to have non-neuro-related diagnosis. In the neuro population, the mean age was 49 and in non-neuro it was 47. So comfort score was applied between 2 charts. It was 14.87 in Ishihara and 15.77 in eye handbook. So the CAPA agreement between Ishihara and eye handbook was 88.3%. Those who not able to read all the plates in both charts, sensitivity is 70%. Those who read all plates in both charts, specificity is 98%. So for the neuro cases, the sensitivity is 88% and specificity is 100%. Coming to the benefits, in patients who are on ATT, anti-tuberculous treatment, it is useful for diagnosing the early signs of toxic optic neuropathy and also aids physician in titrating the doses accordingly. It is easily accessible. It does not require any special efforts for preserving or handling. Multiple patients can be assessed simultaneously. It has some limitations. Since a wide variety of smartphone screens are available like LCD and LED, no standard established screen quality and visibility is available. So the difference in the screen types and brightness can also affect the results. Coming to the uses, it can be used as an effective screening tool that enhances the quality of eye screening at the vision centers and primary health centers, school and occupational screening programs in detecting the ocular blindness yearly. Early detection of conditions like optic neuritis and toxic optic neuropathy allows for timely referral and management. So I conclude by saying that smartphones offers a convenient and more accessible alternative to Ishihara plates, but lack of standardization is a notable concern. In terms of standardization, Ishihara plates are a more reliable choice. However, both factors can be taken into account. Thank you.
Thank you. It's a good study you have initiated. Just one question. Was only one person who was taking, or there were multiple persons who were there involved when you were doing this study? Or did you train a group of people to take
No,
out the
ma'am.
study?
Like we both did, ma'am. One sir and myself. He'll be checking in Ishihara. I'll be checking in the application.
Okay, so there is no inter-bias.
No, yes, ma'am.
Okay, thank you.
I was just having one thought after seeing your study. Is just that you could have like taken different illumination and in your smartphone and continued with the study. Maybe that would have been a more robust study. Then you could have like compared at what illumination is the Ishihara similar or almost similar to your smartphone, isn't it?
Yes.
Yeah. So
Yeah. It's a very good presentation, but I think as an old timer we would still stick to our Ishihara chart, because the chart is big, isn't it? When you compare it with the mobile, and the chart is, illumination also, of course in mobile you said it can be altered, and the cost factor is one I think you did not touch upon, is the cost.
For this app,
Yeah.
ma'am, it is free. It is a free app, ma'am. It is available in Play Store. We can download even in Android and iPhone.
Okay, it's a free app. And you said some of the patients, had a monocular color blindness. So could you please, tell me few causes for monocular color blindness? Few causes.
Traumatic optic neuropathy non-arthritic ischemic optic neuropathy,
Okay, bilateral.
toxic optic neuropathy, glaucomatous optic neuropathy. Due to cataract also they can have defective color vision.
Yeah.
Drug-induced,
Pardon?
drug-induced
Drug-induced, yeah. Toxic amblyophias.
toxic
Commonest
amblyophias. Yes.
in our country, alcoholic and tobacco.
Yes, ma'am.
Thank you.
Thank you.
Speaker.
Has Anvita's, has it been solved, resolved? Okay, please come.
Yeah.
Good afternoon, everyone. My study is based on study on ocular manifestations of NF1 type 1 at Tertiary Care Teaching Institute. Neurofibromatosis is an ocular neurocutaneous syndrome with multisystem involvement, characterized by cutaneous neurofibromas, scapholate spots, axillary and inguinal freckles, leash nodules, orbital neurofibromas, and optic nerve gliomas. The aim of my study is to identify common ocular manifestations, assess the impact on vision, and highlight the importance of early intervention. This is an observational study done at Rio RIMS Ranchi, including 36 NF patients. The diagnosis was based on national NIH consensus. A detailed clinical assessment was performed, including history taking, visual acuity assessment, slit lamp examination, fundus evaluation, and imaging where necessary. These are the inclusion and the exclusion criteria. Results. My study included 36 NF patients, 21 were female and 15 were male. Age of presentation. This chart depicts the age of presentation. Majority of patients presented at the age of 46 to 60 years. This is a chart depicting the ophthalmic manifestations noted. Leash nodules were noted in 30 patients. Neurofibromas on eyelid and eyebrows was noted in 30 patients. Plexiform neurofibroma of eyelid was noted in 8 patients. Orbital neurofibroma was noted in 8 patients. Coloboma of choroid with macular involvement was seen in 1 patient. These are the images. Visual acuity of patient. Vision more than 6 by 12 was seen in 24 patients. Visual impairment was seen in 12 patients. Out of the 12 patients with visual impairment, the cause of amblyopia was only due to plexiform neurofibroma in 3 patients, only orbital neurofibroma in 3 patients, both plexiform and orbital neurofibroma in 5 patients, coloboma choroid in 1 patient. The genetic pattern of disease transmission. De novo mutations were noted in 8 patients. 2 generation affected was seen in 9 patients, and more than 3 generations affected was seen in 9 patients. Neurofibromatosis is a group of autosomal dominant disorders characterized by neurocrystopathies leading to the development of benign and malignant tumors at an increased frequency. NF1 gene is located on chromosome 17 and has a high mutation rate with up to 50% of cases caused by de novo mutations. Diagnosis of NF1 is primarily clinical based on NIH consensus development criteria, requiring at least 2 of the following: 6 or more scapholate spots, 2 or more neurofibromas, axillary inguinal freckling, optical nerve glioma, 2 or more leash nodules, characteristic osseous lesions, or a first degree relative with NF1. About 25% of NF patients develop complications including plexiform neurofibroma, optic nerve glioma, orbital neurofibroma, and neurofibrosarcoma. Orbital neurofibroma, the most common cause of amblyopia in NF, accounts for 0.8 to 3% of histologically confirmed orbital tumors. Localized orbital neurofibromas typically presents in young or middle-aged adults. Early diagnosis and treatment of plexiform neurofibroma, orbital neurofibromas, and optic nerve glioma reduce the risk of amblyopia and compressive optic neuropathy affecting 5% of the NF patients. Management of localized orbital neurofibroma involves total excision, though post-operative sensory skin deficits occur in 72% of the cases. Complete tumor dissection is possible in 46% of cases. Plexiform neurofibroma is treated with excision and eyelid reconstruction. So I conclude from my studies is uh, leash nodule is leash nodules in the iris and neurofibromas of eyelids were the most common manifestation of NF patients in my study. Visual impairment occurred in 33% of the cases due to stimulus deprivation amblyopia or compressive optic neuropathy, which could be mitigated with early diagnosis. De novo mutations accounted for 50% of the cases. These are my references. Thank you.
Thank you for presenting this case. So what exactly this study wanted to find out? Only the ocular manifestations in neurofibromatosis or something else you wanted to see?
Ma'am, I want. Yes,
Yeah,
ma'am.
so you told list nodule is the first which is common.
Yes.
So did you see any optic nerve gliomas in your cases?
Yes, ma'am. Only one patient had optic nerve glioma.
And how do you manage these cases? How do you manage the amblyopia therapy in these cases? You are saying most of them had amblyopia. So what did you do? Because most of your patients are already in the age group of 40 above, you are saying.
Yes, ma'am.
So how can amblyopia build in after such a age? So that means they must be having a manifestation earlier. Did you take that history also into account?
Ma'am, history was noted. Yes, ma'am. I'm getting.
So, did you do some kind of correlation or association between the different types of clinical presentations that you found? Like, if this is there, then that might be there. Did you find that kind of association in your study? Although the number is very less, I agree, but still, was there any kind of association like this?
Ma'am, the patients had like most of the patient they had leash nodules and I'm sorry, ma'am.
Okay.
Thank you,
Yeah.
ma'am.
Yeah, what, yeah. What was the incidence? Did you compare the incidence of neurofibromatosis in our country along with the Western world? Do you find any difference, in the incidence of neurofibromatosis in our country compared to the Western world? Do you have any statistics about that?
No, ma'am.
Okay.
So you just you collected the neurofibromatosis patients and saw the ocular
Yes, ma'am.
presentation.
Yes, ma'am.
Do you feel that as madam had asked a question, amblyopia related to optic nerve, neurofibroma?
Yes,
Do you
ma'am.
think is there a role of once you have eh, what was the treatment that you did? You excised the tumor was excised, the neurofibroma on the optic nerve was it excised?
Ma'am, it was not done in our center.
What okay. So do you see any role of neuro neuro rehabilitation or rehabilitation in these cases where there is an amblyopia or a loss of vision at the age of 40, 45? Because all your series were elderly, middle-aged patients, right?
Yes, ma'am. Yes, ma'am. Rehabilitation.
Anything that you did for the cosmetic reasons? Because I see many patients with neurofibromatosis, they have a lot of complex, isn't it? Because they have lesions all over the body,
Yes, ma'am.
isn't it? It's a big social stigma.
Yes, ma'am.
So, do you feel that there is any role of a psychiatrist or a counseling for these
Yes,
patients?
ma'am. There definitely is a role for psychiatric counseling, and also, ma'am, cosmetic surgery, plastic surgeries also play an important role in rehabilitation of these patients.
Thank you.
Thank you, ma'am.
So next presenter, Dr. Smriti Soni.
Next presenter, Arpita.
Next presenter is Arpita. You're there? You're ready? Okay. Fine.
Shall I begin, ma'am?
Yeah, please.
Yes, ma'am, that's the first slide. As I delve into my topic, I would like to bring to your notice an entity known to all of us, but may probably not have pondered much about. This is the Heinrich Safety Pyramid, which shows the link between the volume of accidents causing significant, minor, or no injuries. But why bring this up here? Merely because I would like to pose an analogy with ophthalmology, wherein certain diseases, if detected early on at this stage, would narrow down the number of irreversible visual loss cases at this stage. And here comes one of the most important assets in our quest to tackle visual loss. A very good afternoon to one and all present here. A 17-year-old girl with no significant medical history has been on regular follow-up at a primary eye care vision center since 2019 and was consistently prescribed glasses where she took up full correction. However, during her visit to our center in the year 2022, the vision center technician noticed a significant decline in her uncorrected vision. Her right eye dropped to 624 and the left eye also showed a similar decrease, which improved to 6/6 with adequate correction. By her 2023 visit, her vision had worsened further, dropping to 6/60 in both the eyes. Importantly, in these visits, her anterior segment examination remained normal and the fundus showed no significant anomalies. However, during her 2024 visit, while her uncorrected vision remained 6/60, the right eye only improved to 6/18 with correction. This prompted the technician to evaluate the fundus, during which blurring of the disc margins was noted. Given this finding, we referred her to the base hospital for further evaluation. At the base hospital, all routine investigations were proved to be normal, and the fundus findings from the vision center were confirmed here. An MRI of the brain and orbits was conducted, revealing a heterogeneous, brilliantly enhancing lesion from the posterior segment of the right optic nerve, which was suggestive of an optic nerve glioma. Given the small size of the lesion, the oncologist recommended regular follow-up and to follow up for a biopsy if there was any progression in the future. Whole body scans taken months later proved uneventful. Her recent visit a few months prior revealed a decrement in vision by 1 line, but the patient was otherwise asymptomatic. Optic pathway gliomas primarily affect children under the age of 10, accounting for 3 to 5% of childhood CNS tumors. 71% of cases occur in the first decade and 90% by the age of 20. Many patients with optic pathway gliomas, particularly those with neurofibromatosis, are asymptomatic. When symptoms do arise, visual loss is the most common, regardless of tumor location. And this is often accompanied by relative afferent pupillary defects, field defects, and color vision deficits. Typically, fundus changes suggest optic atrophy, but in our case, the disc swelling was noted, probably because of an earlier diagnosis. Dodge classification typically categorizes optic nerve involvement as stage 1, but was excluded in our patient. Its management depends on tumor progression and visual acuity loss. As defined in a study, progression is marked by a loss of 2 lines in a Snellen chart. As our patient showed no progression, in 6 months, no treatment was recommended. The risks of biopsy outweigh the benefits, and regular follow-ups are planned to monitor progression. Our patient initially had a gradual vision decrease attributed to refractive error, but was later diagnosed with a different cause at a vision center. Thanks to our advanced telemedicine system, continuous connectivity between the ophthalmologist at the base hospital and the patient was maintained, enabling timely referrals and effective management. Ongoing training and updates in investigative techniques further support these technological advancements. To conclude, this case demonstrates how a thorough clinical examination, even in a primary healthcare center, can uncover serious unexpected diagnoses like an optic nerve glioma. If not for our well-trained vision center technician, much damage would have been done to the girl's sight, and the girl would have lost out on her vision and her future. This underscores the importance of regular follow-ups and detailed clinical evaluations as facilitated by vision centers, which aid in accessibility to quality healthcare. A superficial correction of a presumed refractive error could perhaps mask what lurks deep within. Thank you.
Thank you. A very good presentation.
Thank you, ma'am.
So, what was your basic aim of presenting this case? Was it to show the trajectory of how from the community we can get the cases and treat them, or was it basically how we are going to treat after knowing the optic nerve glioma?
I wanted to highlight how if we have focusing on well training our vision center technicians, even at a primary healthcare level, where there are people who are not able to access good ophthalmic healthcare because they are they stay far away from a tertiary healthcare center. Even with the help of vision care centers, we are able to train them enough, and early diagnosis of such conditions can stall it at an earlier stage, so that if diagnosed earlier, we can constantly monitor
for
the.
that part, it is very good. You are giving a thing that we should get to the community and get this
Yes, ma'am.
cases to be done. But coming to your base hospital, what will be your treatment planning or algorithm when you are finding this optic nerve glaucoma
Yes,
now
ma'am.
at your center?
Yes, ma'am.
Yours is a tertiary center.
Yes, ma'am. So at a tertiary care center, first we would localize where the lesion is. And then based on the size of the lesion and where it is located, we will check for progression. So usually in these cases where there's primarily just a vision care.
Be very basic to your case, because I don't want your case was there. In that, what was the next prognosis in these cases?
Yes,
Did you
ma'am.
refer to a neurosurgeon? Did they any excision, or it's not a biopsy every time, but did they go about or a chemotherapy in these cases, or you are just following the case up?
In our case, we initially waited for a 6-month follow-up. Prior to that, we had gone to an oncologist. He suggested a biopsy or a chemotherapy if there was any sign of progression. So since there was just a visual acuity loss of less than 1 line, after 6 months, we had done no intervention per se. So we will monitor for progression, ma'am. And if there are signs of progression, that is in this case, if there is at least a 2-line loss of visual acuity, we would intervene by chemotherapy, because in biopsy, considering the location, it would be more risky than the actual benefits of a biopsy. Yes, ma'am.
Very nice presentation.
Thank you, ma'am.
So, what's your protocol normally of following up these patients? How do you follow up these patients?
In such cases, we follow by 3 to 6 months. In our case, we stuck to a 6-month follow-up period. So initially this patient presented to us 6 months back. So the latest presentation,
So
we
what all
first
do you do in the follow-up?
we check for visual acuity, we check for field defects, color vision defects, and we can take an MRI if there is further progression. So by the baseline investigation,
You don't do MRI in all the visits?
not necessarily, ma'am. We check the financial constraints of the patient as well, ma'am. So here, since the visual acuity just decreased by 1 line, we told the patient to follow up after 3 months, and if we find further visual acuity loss, we would insist on an MRI, ma'am.
Thank you.
Yeah. So the the treatment part was just observe and follow up, right?
Yes, ma'am. as
Isn't
of
it?
now.
So do you feel that there are, since it's a telemedicine, talk that you're giving, there would be many more conditions where you can, do a justice, detect early and treat, isn't it?
Yes,
Of course,
ma'am.
this case was no doubt a very good case.
Yes, ma'am.
But there would be many more such ophthalmic conditions where you detect early
Yes, ma'am.
and prevent, fall of vision or blindness, isn't it? For
Yes, ma'am.
example, birth asphyxia,
Yes, ma'am.
isn't it? If you're in a tertiary, if you're in a peripheral center, and if there is a child, who is being delivered either with a forceps or with a vacuum or with a, everywhere I don't think for the delivery the doctors are available. So if Japa lady, what they call, if she's delivering the child, isn't it?
Yes,
The child can have, asphyxia, cause a brain damage, where you have to immediately treat, otherwise the child can have, cerebral visual impairment, cerebral palsy child, isn't it? So these are the conditions where acutely you need a management. But the case that you presented was just observe, wait and watch, isn't it?
Yes, ma'am.
Yeah, thank you.
Ma'am. Thank you, ma'am.
Next.
So the next speaker is Arpita.
Is Dr. Kausalya there? You're there? Okay. Ready? You're ready with your presentation, no? After this? Yeah. And the last speaker is Lubna.
Aparajita. Next is Aparajita.
Okay. She is?
Arpita.
She's Arpita.
Yes.
Okay, Arpita.
She's Arpita.
Yeah.
Good afternoon, everyone. Today I am presenting Unraveling the Causes of Optic Atrophy, its etiology and implications. So, optic atrophy is not a disease, it is a morphological sequelae of disease. These are the late changes that occur in the optic nerve. In this process, axonal degeneration occurs in the visual pathway between retina and lateral geniculate body. And there are various causes of optic nerve shrinkage like ischemia, inflammation, compression, infiltration, and trauma. So, we have primary optic atrophy that occurs without any antecedent swelling of optic nerve head, secondary, which occurs due to long standing swelling of optic nerve head, consecutive, which causes disease of inner retina and its blood supply, and glaucomatous, where there is deep cupping and nasal shifting of blood vessels. So, as we know that there is no effective treatment of optic atrophy, and the only solution is control of risk factors. So, early diagnosis and treatment of the cause is essential for better visual outcome and general health and life of the patients. So, in our study, we have evaluated the various etiologies of optic atrophy. So, it was a cross-sectional study performed at Dada Viren Puri Ji Charitable Eye Hospital, Jabalpur, for a duration of December 23 to May 24. Inclusion criteria was patient diagnosed to have optic atrophy on ophthalmic examination, and exclusion was not willing to participate in the study. So, methodology: disc pallor with diminution of vision, demography, etiology of disease, ophthalmic examination was conducted, visual acuity, pupillary reaction, and posterior segment examination. Data collection was done, demographic information was taken, medical history, any medication use, symptom course, paraclinical evaluation, neuroimaging, and visual outcome. So, we found in our result that 86 patients with optic atrophy were found, out of which 50 were male and 36 were female. Mean age was 45 years, ranged from 11 to 80 years. So, highest occurrence of optic atrophy was seen in 61 to 70 years age group. 31 cases were unilateral and 55 were bilateral. So, primary optic atrophy was seen in 26% of people, secondary was seen in 16, consecutive 10, and glaucomatous was seen in 34. So, in our present study, out of 86 patients, 50 were male and 36 were female. The disease was bilateral in 55 and unilateral in 31 cases. Highest occurrence was seen in 61 to 70 years age group, and glaucomatous optic atrophy was seen in 34 cases, and most cases were of primary open angle glaucoma. So, in a similar study performed by Bajracharya et al., titled Epidemiology and Causes of Optic Atrophy in General Outpatient Department of Lumbini Eye Institute, this was a cross-sectional study and 100 cases of optic atrophy were seen. In this study, 50 were male and 46 were female. The disease was bilateral in 26 patients and unilateral in 74 patients. In this study, glaucoma was the main cause of optic atrophy. In another similar study performed by Nayak et al., study of etiology of optic atrophy, this was a hospital-based cross-sectional study. From July 2017 to August 2018, 100 cases were included. In this also 62 cases were male, 38 cases were female, and 70 cases were bilateral and 30 cases were unilateral. In this study also, glaucoma was the main cause of optic atrophy. So, optic atrophy causes irreversible loss of vision. Hence, awareness about the etiology, early diagnosis, and treatment remains the mainstay for improving visual outcome and providing better quality of life to the patients. Glaucomatous optic atrophy was commonest presentation in our case, so awareness and early treatment is the only way to reduce its burden. Thank you.
Thank you for the presentation. So, how many cases did you take? So, was there a bias, or don't see any neurological cases where other than that also, like brain tumors and all, or only glaucoma was more into the session?
Ma'am,
So, which was the second highest cause for optic atrophy in your case?
Glaucoma was the main cause, followed by primary optic atrophy, and then secondary, and then traumatic.
So, what was the most common in those primary causes?
Pituitary adenoma, we first of all when patients came to our for our hospital, then we sent them for MRI and we found that
you just did
pituitary.
a observational study or any other correlation? Have you taken the OCT on all those in the
Yes,
picture?
ma'am. We have taken those who were having pituitary adenoma. They were sent to neurophysician for the further management. And for glaucomatous optic atrophy, we took over the cases to treat them, and for traumatic also. Like all the ophthalmological causes, we took over. And
So was this a prospective study or a retrospective study?
ma'am, retrospective also.
This was a retrospective study. So how did you distinguish between a primary optic atrophy and a neurological cause of optic atrophy?
Ma'am, neurological, we had the data also, and from the data itself we came to know.
So you have scanned the data, the hospital data of these.
Yes, ma'am.
Okay. So what was the second most common cause?
Ma'am, glaucoma, then primary like optic neuritis.
You just said
Yes, ma'am, under primary like pituitary adenoma.
it would have been nice if you had enumerated the other causes that
Yes,
you had
ma'am.
seen, isn't it?
Yes, ma'am.
Thank you.
Okay.
How many optic nerve fibers are there in a normal person? In an optic
millions.
disc, how many optic nerve fibers are there?
Ma'am, 2.5 billions are there.
And how did you differentiate, partial optic atrophy to complete optic atrophy? I mean, the studies that you carried out, was it a complete optic atrophy or a partial optic atrophy?
Ma'am, we took over mostly complete optic atrophy, and our main focus was distinguishing whether it is primary based on the appearance of the disc, like if it is grey, well-defined margins are there, and the etiology of the disease. According to it, we graded as primary. Then secondary, ill-defined margins are there, post-neurotic or post edematous disc are there, so we distinguish according to it to secondary. Then we went to consecutive, like if there are any retinal pathologies like retinal pigmentosa is there, or any other consecutive those related to retinal pathology, CRVO, or any ischemic, post ischemic, so we distributed to consecutive. Then traumatic, patient giving history of any trauma, and so we distinguished into traumatic, and those having
Where does AION fit in? Anterior ischemic optic neuropathy. In your classification, where does that fit?
ma'am, primary.
Okay, thank you.
Thank you.
So next presenter is Aparajita.
Yeah. You want to take? You want me to take after this another three? So from these speakers, what these three? Okay.
Okay. Good afternoon, everyone. I'm Dr. Aprajita Bondili. I'm here to present a study on etiology of acute loss of vision in patients presenting to the Neuro-Ophthalmology department at a tertiary eye care center.
Because I want to talk again, then that could be postponed. So we'll continue as a judge.
Acute vision loss in neuro-ophthalmology is a significant and often an alarming clinical symptom with profound implications of both diagnosis and management. Now, it encompasses a wide array of pathologies necessitating a nuanced approach of diagnosis and management. Neuro-ophthalmology department specializing in disorders where neurological and ophthalmic issues intersect is pivotal in the evaluation of these complex cases. So my study is retrospective. The purpose is to analyze the causes of acute loss of vision in patients presenting to the neuro-ophthalmology department at our tertiary eye care center. To provide comprehensive overview of contributing factors, methods, we analyze the hospital data from a tertiary eye hospital within a time span of 6 months, spanning from July 2023 to December 2023. The results were, out of a total of 5,799 patients coming to the neuro-ophthalmology OPD in a time period of 6 months, patients with acute vision loss were 787, with a percentage of 13.57 and average age of presentation being 49 years. The diagnosis included were non-arthritic anterior ischemic optic neuropathy, optic neuritis, traumatic optic neuropathy, toxic optic neuropathy, cortical blindness, orbital apex syndrome, LHON, peripheral vision loss which includes field defects, and arthritic anterior ischemic optic neuropathy. The percentage distribution of the diagnosis were as follows. As you can see, NAION had the most common presentation with 33.5%. Being the most common presentation, we evaluated the comorbidities as well. Diabetes being the most common comorbidity with 66.67%, followed by hypertension at 42.04%, followed by hyperlipidemia and cardiac diseases. The mean age of acute vision loss was found to be around 48.9 years, with LHON being presented at 27 years. So the discussion, average age of presentation was around 49 years, with NAION being the most common diagnosis at 33.5%. This is in alignment with results obtained by Lensworth et al., where NAION showed the highest percentage of in patients with acute optic neuropathy. The systemic associations were diabetes, followed by hypertension and hyperlipidemia. Optic neuritis is the second most prevalent diagnosis. It was commonly seen in patients in the 4th decade. Traumatic optic neuropathy was the third most prevalent disease, with 19.4% patients diagnosed with it. In contrast to other causes of acute loss of vision, the average age of presentation of LHON is in the 2nd decade of life. Notably, AION was not reported in any of the 787 patients. The take-home message of my study is that NAION was the most common diagnosis, with the most prevalent comorbidity being diabetes followed by hypertension. Diabetes and hypertension management is key in reducing risk and progression of NAION. Coming to traumatic optic neuropathy, it accounts for 19.4% of cases. The use of protective headgear can significantly reduce its incidence, and AION was not reported in the study population of 787 patients, suggesting it may be a rare in this group. These are my references. Thank you.
Thank you. So actually we are running out of time, so I call the last presenter, Dr. Ashwin, to come and present. Sorry, Lubna, no? Okay, come.
Good afternoon, everyone. I'm Dr. Lubna. So my title is Sweet Galaxy Eyes. It is based on asteroid hyalosis, which is a common degenerative condition of the vitreous gel. It is benign in nature. So it has a characteristic appearance of stars or asteroids in the night sky, and it was first described by Alfred Hugh Benson in 1894. Hence, it's also called as the Benson's disease. It is an asymptomatic condition, and the pathogenesis is not clear. We see calcium pyrophosphate crystals which are collected within the vitreous. The aim of my study was to study the relationship between asteroid hyalosis and diabetes mellitus. It is a cross-sectional study which was done over a period of 6 months. Patients who were diagnosed with asteroid hyalosis were selected, and my exclusion criteria was patients with hypertension or other systemic conditions, previous history of retinal or vitreous disorders, or mental retardation. About 60 patients diagnosed with asteroid hyalosis were selected. They were divided into 2 groups, Group A and Group B. Group A had patients with diabetes and Group B without diabetes. Ethical committee clearance and informed consent from patients were taken. Detailed history of all patients was taken. The ophthalmic examination included visual acuity testing, anterior segment examination using slit lamp, posterior segment examination using IDO, and the random blood sugar of the patients were recorded. Results. So in Group A, we had around 42 patients who were diabetic. Group B had 18 patients who were non-diabetic. So in Group A, around 64.2% were males, while 41.35% of them were females, whereas in group B, around 10 males and 8 females. Eye involvement, it was noted that the bilateral involvement was more than the unilateral one. In group A, we had 42.85% unilateral eyes involved, whereas in group B, we had 44.44%. The p-value was found to be less than 0.001, which was extremely statistically significant. So here in our study, we have
कुछ क्वेश्चन और मत पूछिए.
So the causes and mechanisms of asteroid halosis remain unknown. In our study, we noted that it was mostly seen in males. The condition was mostly seen in males. It was mostly a bilateral condition, and most of the patients that we had noted were diabetic.
इनको क्वेश्चन नहीं पूछेंगे, जो they will just press.
In previous studies, we've seen Zinn, who reported 27% patients with asteroid halosis were diabetic, and Berggren noted around 29% patients who had asteroid halosis. So my conclusion is there's a significant association between asteroid halosis and diabetes mellitus. People who are observed to have asteroid halosis as an incidental finding should be screened for diabetes mellitus. Nil financial disclosures. These are my references. Thank you.
Thank you. So we come to the end of this neuro-ophthalmology session 4 session. So we have 3 more presenters. So I call upon Dr. Farnash. हो गया.
Hi, hello, and a very good afternoon. Optic nerve glioma and optic nerve sheath meningioma. So are these tumors a clinico-radiological diagnosis? If so, why is it still a diagnostic difficulty? Let's find out. Optic nerve gliomas comprise 1% of all the intracranial tumors, whereas meningiomas are the second most common after optic nerve gliomas. So now, why is it considered as a diagnostic difficulty? The first reason being the rarity of the disease, and the second usually getting misdiagnosed most commonly as optic neuritis, thereby leading to all the problems as listed on your screen. Ours was a retrospective study where we analyzed 36 optic nerve tumors, 15 gliomas and 21 meningiomas for the following. The mean age was 15 years among the glioma patients, with 53% males, and 43 years in the meningioma group, with 57% being females. The main clinical features were protrusion of the eye, diminution of vision, strabismus, extraocular movement restriction, disc changes, normal being in almost 13% of the people, followed by mild disc pallor, severe disc pallor, hyperemia, and also optociliary shunts and choroidal folds. The mean duration of symptoms among the glioma patients was 52, and among the meningioma patients was 73 months, with the most important clinical features being protrusion and diminution of vision. The appropriate imaging for optic nerve tumors is MRI brain with orbits, plane and contrast. On the left, glioma demonstrated by the enlargement of the nerve itself, hypointense on T1, whereas a soft tissue mass along the nerve sheath, hypointense on T1, is meningioma. In T2 weighted images, glioma is definitely hyperintense, whereas meningioma is iso to hypointense. Contrast enhancement seen in both the tumors. Gliomas, however, irregular and botchy, whereas meningiomas with circumferential enhancement with a centrally non-enhancing optic nerve. The two classic radiological signs of meningiomas are the tram-track sign in axial cuts post-contrast and the donut sign in coronal cuts. The patterns of meningioma enlargement can be tubular, the most common, followed by globular and fusiform with tapered ends, and the fusiform variety is usually confused with glioma. Type 2 being extension to optic canal or supraorbital fissure, and type 3 with intracranial extension. Treatment strategies in our series, chemotherapy was given in 7%, usually under 3 years of age group until the child gets fit for radiation, and 67% received radiation therapy. Among the meningioma patients, the widely used treatment strategy was stereotactic radiation among 95%. So EBRT in such cases, T1 weighted axial and coronal images with contrast are registered with the planning CT, followed by gross tumor volume being the area of contrast enhancement, and this gross tumor volume when expanded with 1 centimeter in all directions gives you a planning target volume. The target specific gradient of radiation therapy, the area of tumor, which is the area of interest, receives 95% of the prescribed dose of radiation, followed by the surrounding area receiving 50% and further surrounding area receiving 20%, thereby preventing collateral damage. So let's have a look at few of our patients. First, glioma, who had excellent vision, and also there was significant reduction in the tumor volume after EBRT. Same for the meningioma patients as well, pre-EBRT and post-EBRT images. So our study, how does it stand out from the others? So here, both optic nerve gliomas and meningiomas were analyzed. However, separately. So diminution of vision and proptosis were the main clinical features. MRI brain with contrast enhancement was done in all 100%, and EBRT was done in the glioma group with 67%, leading to 72% good visual outcome. Among the meningioma group, 95% received EBRT, still 90% had good visual outcome. So yes, optic nerve gliomas and meningiomas are diagnosed clinico-radiologically, thereby restricting surgical intervention only to cases with disfiguring proptosis and intracranial extension. So early diagnosis with accurate requisition of MRI, precision of reporting, easier access to neuro-ophthalmologists, ocular oncologists, early diagnosis thus, and then accurate treatment with EBRT, thereby leads to better visual outcome or stability. Thanks a lot.
Thank you. So I call upon Dr. Chaudhary to present her.
यहाँ पे दादा, यहाँ ये वाला 2455. Good afternoon. My paper is Genie in a Bottle, Reversible Nutritional Optic Neuropathy in Northeast India. I do not have any financial disclosure in this presentation. Of the various colors of Northeast, the Mar, Mizo and Naga hail from in and around Assam. I hail from Kachar, so I get a lot of these patients. The background of our study is India has the largest market of smokeless tobacco, and incidentally, Mizoram has the highest amount of tobacco consumption. What is not known is the liquid entity, tobacco entity, and its ophthalmic sequelae. The purpose of our study is to report reversible nutritional optic neuropathy in 43 young and healthy patients belonging to the indigenous tribal community of Northeast India. They all presented with diminution of vision in both eyes, and they gave history of liquid tobacco intake. It is a retrospective case series. Detailed medical and dietary history was taken. Clinical evaluation included color vision, visual fields, and the OCT studies. Demographic profile was taken into consideration. Duration and frequency of liquid tobacco use was also noted. So what is this liquid tobacco? I had seen patients sipping this brown colored fluid from a bottle in their hand. I was really intrigued. The local name is Tuibur or Hedakfu. It is a form of tobacco water, very popular in northeast states of India. It is a part of their social customs. It has a wide culture and social acceptance, so much so that it is as common as tea or coffee. And they have a misconception that water purifies the tobacco. I visited a Mar village to find out the production chain of this tuibur. Here the tobacco is dried up and then it is set to fire in these earthen pots. The pots are connected to glass bottles, and with the help of a hand pump, the smoke is infused or percolated into the fluid till the time the fluid is supersaturated. Then a cloth filtration is done, and then this is the final product, which is the brown colored liquid. So what is the mechanism of toxicity stripping? Volarimetry of tuibur has shown the presence of heavy metals, myosmine, carbon monoxide, and cyanide. All these cause mitochondrial DNA damage, resulting in reduced mitochondrial respiration, reduced ATP, increased oxidant stress, which finally causes demyelination. All the patients were started on vitamin B complex. Along with methylcobalamin, they were advised to discontinue tobacco use. Out of the 43 patients, 83% were female. Mean age was 29 years. Tuibur intake was mean of 7 years. The ethnicity showed 61% of them were Mar. Another 30% belonged to Naga, Kuki, and Mizo community. These are some of the cases. The first case here, normal looking fundus, normal OCT RNFL, but in the 30-2 you will find central scotoma, the first figure at presentation, and then after 1 month of treatment, central scotoma comes down. Another case presenting with temporal pallor, RNFL showed some temporal RNFL thinning. Again, central scotoma, and at the end of 3 months you can see total disappearance of central scotoma and vision also improving remarkably. So the vision, logMAR vision at presentation and after 3 months had a statistically significant improvement in the vision. The beneficial effect of vitamin B complex with B12 is because of conversion of free cyanide to cyanocobalamin. All 43 patients who presented with bilateral diminution had statistically significant improvement in visual acuity and visual field indices. As you can see here in the visual field index and the pattern standard deviation at presentation and at 3 months of presentation, the difference is statistically significant. Though there has been some studies of tuibur and the connection to stomach cancer and some local studies from Manipur and Mizoram, this is the first ever study linking liquid tobacco or tuibur to toxic nutritional optic neuropathy. We conclude that nutritional toxic optic neuropathy can be caused by a multitude of agents. Mainstay of treatment involves definitely replacing the deficient nutrients. Eliminating the offending toxins has to be done, and it is very important to consider contributory social, cultural, and dietary practices. Thank you very much for your kind attention.
Thank you. So I call upon the last presenter, Dr. Prativa.
अभी तो डाला हुआ था ना उन्होंने just ask this guy, he has put presentation.
We are extremely sorry for this delay. Unfortunately, we got the hall, half an hour late, and there were some technical issues where the hall manager could not give us the papers to judge. So we are really sorry for that.
दिया ना कब का दिया हुआ
Technical glitches like this also, so it was getting delayed for this also.
लिखा था ना आपने वहाँ पे
A very good afternoon to all. So I'll be discussing about the case series of unusual headaches in children. The slide does not move. Headaches are a very common and disabling problem for children and adolescents, and 60% of the children experience at least 3 headaches per year, and similar trend is seen in India as well. The commonest cause being migraine and tension type headache. Headaches in children are frequently attributed to benign causes, however, persistent or atypical headache warrant a deeper evaluation. So this was a case of a 5-year-old child who presented with holocranial headache, increased in frequency since the past few weeks. He had occasional vomiting, unusual episode of crying due to headache, and he had consulted a pediatric neurologist who started him on treatment, after which the headache reduced in intensity. So when he presented to us, the visual acuity was 6/6 and 6, pupil color, contrast, anterior segment and fundus was normal. After 20 days, the child's headache worsened again, and at this visit he presented with early disc edema. And you can note here there is presence of subarachnoid fluid on B scan. He underwent a neuroimaging where a large cystic mass was noted in the left temporal region, suggestive of an arachnoid cyst. He underwent a left temporal mini craniotomy and endoscopic fenestration of the arachnoid cyst, and there was resolution of the subarachnoid fluid. This was a case of a 14-year-old child who came with holocranial intermittent headache since 2 years, which relieved after rest, and there were no aggravating factors. Her visual acuity was 6/6 and 6 with mild compound myopic astigmatism. Pupil color, contrast, anterior segment and fundus was absolutely normal. The child was prescribed glasses and was advised to consult a pediatric neurologist if the headache persisted. However, to our surprise, she comes back again after 3 weeks with sudden drooping of the right eye upper lid. Her visual acuity was 6/6 and 6 with right ptosis, left face turn and anisocoria, where right eye was a larger pupil. Her cover test was suggestive of a right third nerve palsy involving the pupil. Again, a neuroimaging was done, and it was noted to have a large craniopharyngioma which was compressing the right third nerve. Her visual fields were absolutely normal. The RNFL was normal. However, the GCC showed early binasal thinning, suggestive of early chiasmal compression. She underwent decompression procedure, following which the third nerve resolved completely. This was a case of a 16-year-old female child who came with holocranial headache which had increased since the last 1 month. She was a known case of migraine since early childhood, and this visit she described that her headache was something unusual from the previous headache that she would get. The visual acuity was 6/6 and 6. Pupil, color, contrast, anterior segment and fundus was absolutely normal. She was referred to the neurologist in view of the unusual headache, and incidentally on neuroimaging was noted to have a pituitary macroadenoma, which was pituitary macroadenoma. Her visual fields were normal again. The RNFL was normal here, and GCC showed early binasal thinning, again suggestive of a chiasmal compression. So what are the important aspects of headache that we should be aware of? We should know what is the onset and duration, whether it is sudden in onset or progressively worsening over time. The location and the character of headache is very important, whether it's severe or unusual pain, especially in the occipital or bifrontal region. The triggering factors and the timing, like morning headaches, nocturnal awakening, aggravation with activities like coughing and bending, any associated symptoms like nausea, vomiting, visual changes, neurological symptoms, and if the daily routine activity is getting disturbed, like child is missing school, if there is any sleep disturbance or inability to perform routine tasks. One should be aware of certain red flags that you can see along with headache, like systemic signs and symptoms like fever, weight loss, neurological signs like vision loss, cranial nerve palsies or ataxia,
occipital headache in high-risk groups, postural headache, headache in very young children, headache associated with infective signs, squint or papillary edema, waking up from sleep or early morning vomiting or thunderclap headache. We know that MRI is the imaging modality to look for any secondary intracranial cause. However, ophthalmic tools like OCT, visual fields, and beads can also help in clinching the diagnosis early. So what are the lessons that we learn from these cases? So there's a need for a close follow-up, reevaluate persistent headache at least within 1 to 2 weeks. Intracranial compression can present without any alarming red flags, so close follow-up is very important in persistent headache. Pay close attention to patient's description of headache, and timely referral to the neurologist is a must. So I would like to conclude by saying persistent or unusual headaches need more attention. A comprehensive approach is very important. Recognize red flags, utilize advanced imaging techniques which can help to clinch the diagnosis early. Timely intervention will improve the prognosis and reduce long-term complications. And a collaborative effort and awareness among clinicians is a must to treat these children effectively. Thank you.
So we conclude the session and hand over the hall to the next speakers. Thank you very much. And once again, sorry for the delay.
Presenter? Yeah.
Yeah, they're all presenters only, I suppose. Yeah. Thank you. Thank you very much. तुझा मोबाईल मधून घेतला? One more. So she'll put it in the group, yeah, I know. भेजेगी सबको भेजेगी वो. Thank you so much. So this is the concluding ceremony.